Welcome to episode 8 of the ARME Radio podcast, the show where we aim to offer accessible education to healthcare and fitness professionals alike and to bridge academic research to the clinical setting. In today's episode, Dr. Tasha Stanton joins the crew from the land down under. Dr. Stanton is a clinical pain neuroscientist from the University of South Australia. She started her career in healthcare as a physiotherapist and quickly made the jump into the world of academia. Her areas of interest include chronic pain, behavioral neuroscience, sensory neural integration, and she's looked at a variety of conditions including low back pain, osteoarthritis, and chronic regional pain syndrome. Throughout the episode, we discuss the multifactorial nature of pain perception, contextual factors involved in the therapeutic interventions that we use, and we dive into the world of knowledge translation for back pain and for future clinicians. For more information and resources, visit us at www.thearmy.ca, and we hope you enjoy today's episode as much as we did. Yeah, there we go. We are good to go. So Perfect. We have Professor Tasha Stanton with us out of the University of South Australia. Now, we're going to be getting into a lot of good discussion on your current research, what you've done, and what you're planning on. But just for our audience, if you wouldn't mind kind of giving us a brief introduction on how you got started into the realm of healthcare, your early clinical days, and then how you got to where you are today as a pretty important pain scientist, right? So I'll let you take that away.
Sure. So I guess I don't know how many other people came like this out of high school, but I didn't have a good sense of exactly what I wanted to do. And I felt like I really liked sports. I really liked various different things. And that sort of naturally, I think, made me take a look into physiotherapy as something that I might do. So I did my degree out of University of Alberta. And then after that, I began to do some work with quite a challenging population, but the workers' compensation kind of tertiary care. So like a big center where everyone comes after they maybe have failed or not done as well as hoped in primary services. And it was a really good job in a lot of ways and a really, really challenging job. And I felt that so much of what I'd learned or what I had taken away from my training was really not helping me when I was in trying to treat these really complex, help these really challenging patients. And I think it just raised so many questions for me. I didn't have good reasons why I was maybe choosing one treatment over another, or why I, thought I would not do that in this person, or what I should even start on in terms of therapeutic model. And I think that just really made me question a lot of things and look a lot deeper and start to actually look into the literature and see what we know about that. And then realize that actually a lot of that stuff we don't know. And that really spurred me to say, actually, maybe I'll give this research thing a shot. And it had never appealed to me, to be honest. I remember taking our statistics classes and various different things. And I'm like, oh, well, this seems rather boring. But it turns out when you get to ask your own questions and are really looking at things that you do really want to know that answer to, it becomes a lot more exciting. So I did my master's that was actually mainly looking at spinal biomechanics at University of Alberta with Greg Kotchuk, who also has training as a chiropractor. And that was a lot of fun. It was hard, but then kind of got the opportunity to go to Sydney and to train with one of the really strong low back pain research groups there that works more in public health and things like that. And that was an excellent experience to understand, how big trials are set up, how we develop important clinical questions. And then my PhD looked a lot more at how we choose the right treatment for the right people. And that was also really, really good and fun. And then I kind of really got my head into pain neuroscience. And that to me is really where I think it's a beautiful combination of innovation being a rather new field, complexity because you're bringing in so many other different fields, but huge relevance because to me it's been the closest thing that actually captures the complexity of the clinical encounter and of all the processes that are going on in someone's body that has chronic pain. And so that's really where I've been for almost the last, how many years? Quite a few years now, almost 9 years, coming up 10, working in research and in pain neuroscience. So I think a long story short, it came from asking questions and not having those answers, and or not feeling happy with the answers that I maybe got. And it helped very much being an enormous nerd.
Definitely, definitely. Do you find that now, the further you're digging into things, though, that you're just getting more and more questions? That seems to be, along the lines of the Dunning-Kruger effect and everything. You're just opening up more doors, right? So,
Yeah, definitely. And I think that that's a good thing when that's happening,
yeah,
because I mean, we all go through those stages, don't we, where we're kind of unconsciously incompetent and we think we know everything. And then suddenly we're like, oh dear, consciously incompetent. This is fun. So at least I feel like I'm aware of the things that I don't know. And that's kind of a useful place, certainly as a researcher, to be in. And I think it's probably a really good place as a clinician to be in as well.
So, why don't we talk a little bit about some of those early like spine and biomechanics years in your research with Dr. Kotchuk? So you have a series of papers with Mosley, Wong, and Kotchuk on the whole conversation of stiffness. And this is something that from our profession is constantly used as a test, intervention, retest, or as an outcome measure. And it's something that's very frequently questioned. But if you look across the internet, there's still always people talking about how we need to resolve stiffness, facet dysfunction, or whatever that might be. What would you have to say to some of the clinicians out there in regards to spinal stiffness is more of a perception, which is kind of what you guys started venturing into with your work, right?
Yeah. So I guess it actually comes, I think, down to the idea that anything that we experience is ultimately an amalgamation of various different information sources. So that includes sources from the periphery, so things coming from our muscles, from our joints, from our skin. But it also involves a lot of other things that seemingly might not matter to this, but it really does. So things like what our beliefs are, what our past experiences are with our back, let's say, or with a specific movement. It can also, in the amount of sleep that we've had the night before, the amount of expectation that we have for what we're going to do, the fear or anxiety that might be related to that. And all of those things come together to then make and cause this perception to come into our conscious awareness. And we're not aware that many of these things are occurring, but much of the studies that we do then try to explore all the different influences that occur to mold or modulate those experiences or perceptions that we have. So with the area of spinal stiffness, what was quite cool is, so Greg, I think he's a really forward thinker in chiropractic field, and I think you guys would probably agree with me there. And so I love it because he's got a lot of the tools and the toys that allow us to really measure stiffness in a standardized manner quite well, but then allows us to really explore what other things contribute to the feelings that people have while we're ensuring that actually the stiffness of their back itself seems to be remaining constant. So that is a cool thing because it allows us then to explore perception. But so the point, I guess, that where I've gone down the path is this idea of the things that we feel, they're not just readouts of information coming from the periphery. What they are instead is usually most of our feelings have different functions, and often those are homeostatic. So an example being, if I feel thirsty, feeling thirst, it's a perception that I have, and it causes me to then go and seek water. Or feeling hungry causes me to go and eat food. And I was wondering then, what was the homeostatic function of stiffness? And that's, I think, really where our hypothesis came about, that in the function of let's say, of sore back and a back that feels stiff, is it possible that we have stiffness, or the feeling of stiffness, it might actually be protective? Is it something that when the available evidence coming to our body suggests that actually maybe we shouldn't move as much, maybe due to injury, maybe due to beliefs, maybe due to various different things, is it possible that that's reflected in the stiffness that we feel? So it's kind of saying that what's coming from the tissues can matter, but so can all the other things that are surrounding that individual in that situation. And so in the study that we did, that was now a few years ago, we deliberately used the fact that we have these innate processes within our systems that combine sensory information. So if things happen at the same time, our brain in some ways keeps its old functions that are like, all right, same time, this seems easy. They must be happening from the same place. Let's pair them together. And so we use that a bit to our advantage. And also this idea that when you're stiff and you're moving, joints often make noises. They crack, they grind, there's inherent ecological validity to movement being paired with sound. And we see from some of the base literature, there's actually really strong structural and functional links in areas of the brain that deal with these two sensations. But so what we did is we basically said, if we hold everything else constant and all we do is we change the noise that people hear when we apply a pressure to their back, so just like a PA pressure, but using a very standardized machine, what happens to what they feel? And so what we found from that work is that when you provide information in the form of sound that maybe provides data to people that they might not be as safe as they think they are. So in this case, a really creaky, screechy, grindy door that's paired with that, then it changes what they feel. So in this case, we used a corollary measure, but in essence, it meant that they felt more stiff when we paired this creaky, grindy sound. And what was, I think, really cool is when we kept the sound, like the exact same sound, but we just made it less creaky over time. So with each push into the back, it gets less and less creaky. They had a completely different experience. So to me, that shows that it's the meaning behind the sound that is then being integrated into this big, large perceptual experience and influencing stiffness. So that maybe if we manipulate safety and danger of whatever signals being provided, we can then also influence that perceptual response. So to me, I guess that brought together the idea that, yes, of course, peripheral things can contribute to feelings of stiffness. We need to do this study, but if you get people with the spine fused, they may well feel that they can't move as much because they may physically not move as much as well. But there's still in those people, those contributors that are coming from other sources that are can influence that ultimate perception of stiffness.
Really cool. And something that they touch on in school, especially if you're someone who uses spinal manipulation, is they talk about how there's a therapeutic benefit whether or not you hear that pop sound, right? But we still have very little physiologic evidence to say what's actually going on with that sort of intervention besides any of the contextual factors, right? So with what you've sort of found with this study, might we be able to, it might be a bit of a stretch, but hearing those pops or feeling those pops might give someone that sense of a little bit more relief than if they didn't feel or hear that with some of their stiffness?
I would argue probably yes, especially if they have a strong belief that that's what manipulation is. It results in a pop or crack of a joint. And I think manipulation, mobilization, all these things are like a lot of our other techniques that I think it's important, I think, that we understand more how they work and we understand, or if they work.
Yeah,
and
for
sure. But understanding the role of those contextual factors might be way more important, which sounds like we're fobbing off different treatments, but they're powerful things. And if we deny their contribution to an experience, we're being the ostrich with our head in the sand saying, I'm just going to keep doing this how I'm doing this. And I don't think that's helpful as a field or as a profession. And I include physiotherapy, I include lots of other ones in that to go forward.
I'm just kind of curious. You said you came from University of Alberta.
Yeah.
And then you went to Australia after. I was just curious. I know there might have been a time discrepancy, but did you find there was a large paradigm shift when you went down to Australia? Like, I know at least with chiropractors, especially in our area, if they go do a master's, it's usually in biomechanics. And there's a large mechanistic standpoint related to, again, like alignment and all that stuff. And it just seems like a lot of the good pain science is coming out of Australia. It's coming out of cases that, I mean, there are some good researchers in Canada, don't get me wrong, but just seems like the majority of it is coming from those type of areas. I'm just curious if maybe there's a paradigm shift even with clinicians down there.
Yeah, great question. I did notice the shift, so I can probably speak most authentically to physiotherapists. But when I went there, what I noticed and felt was that some of the things that I was taught in Canada, I think we were probably about 10 years behind what was going on, and the paradigm and cultural shifts that had undergone those fields in Australia. And I'm not exactly sure why that is, but it was really quite noticeable. And I certainly felt that in anywhere around the world, there will definitely be people that are really strongly attached to various theories and the way that I think they've been originally taught, and that does exist everywhere. But it just was, particularly in Alberta where I was working, similar to what you're experiencing and describing, is that it was a really, really strong mechanistic underpinning of saying, like, manual therapy courses and doing all the different levels. That was a really big thing. And that is really hard to shift, I think, because I guess what's challenging is whenever we are treating patients and we do something and we see something improve, that gives us, evidence, so to speak, that's worked. But the trouble is so we don't know what would happen in that same person if we just reeled back time and had a lovely chat with them, really explored different things and tried to, let's say, make them feel less fearful, and then see what those two outcomes are. And we can obviously never do that. We try to replicate that in trials, which do have limitations, but are the best way that we can test this. So I think it becomes very difficult to shift opinions because there's this almost confirmation bias that's occurring, saying, but when I do it, my patients get better. And it's, yes, but there's also natural time history, there's contextual effects, there's also regression to the mean, where if you start high, you tend to be lower. So there's all these different things that I think are important to tease out because they're the reason why we should do what we do.
Yeah, that's awesome stuff. Sorry, my niece is just visiting right now and she was saying goodnight. But so moving forward a little bit into some of the other research that you've done, we've looked into, like, I've read some of Daniel Harvey's work with VR, which is really cool with the range of motion through the neck, and some of the stuff you've been doing with arthritis and just changing sizes of limbs. So if you wouldn't mind just kind of talking a little bit about that. I know it was more of a case study sort of thing. It was a smaller scale. Are there maybe some plans at looking into that at a larger scale? And if you wouldn't mind discussing some of the findings that you guys got.
Sure. So yeah, a lot of my research interest has come in the area of sensory manipulation. And the idea being, of course, that we're going to consider lots of different sensory sources to create a robust multimodal experience, such as, things like pain, or even how our body feels to us. And so, yeah, what we've used is it's a technology called mediated reality. And basically what it does is it uses real-time video. And what's really compelling about it is it means that you see your own body changing in front of your eyes. Whereas often virtual reality or other things, whatever you see doesn't look always very real. It's getting much better now, but it certainly didn't used to very much. This is quite compelling. So we were going down this idea that in many conditions, we see that things like just seeing, having vision of the skin of your body, it's analgesic. So an identical stimulus will hurt less if you just see the skin of your body. And we think this is due to innate processes where different parts of our brain basically are kind of talking to each other, and that results in a modulation of a nociceptive signal, or of the ultimate expression of that nociceptive signal. And so what I was interested in is seeing if some of these innate processes that exist in healthy volunteers that we see in lab studies, do they extend to clinical population? But I was interested to see in these people, if we manipulate the perceived size of their knee, and this people with painful knee osteoarthritis, would these innate processes still be there that actually might result in analgesia? So we had people with knee OA and basically used this big setup so that they saw their knee change in size, and we visually elongated it, but also pulled on the calf as muscle towards the foot as we're visually elongating it. And then it's not real. Like, you understand it's not actually happening, but it's the weirdest feeling when you get it, because you're just like, that's very odd. And so we're doing these illusions with people, and we didn't tell them what was the real one. We used lots of different control ones, because I don't want to just find out that it's a cool machine that's distracting. I want it to actually be for the reason we think it's working. And so we did this in a proof of concept study, and we did find that it was analgesic. And we found that if we repeated that illusion numerous times, the analgesia increased, and it was cumulative, it got more. But kind of interestingly, if we just sustained an illusion, so if you stretched their knee out, they just kept looking at it in a stretched out form, we didn't get any further analgesia. So it suggests that there's something going on with the changing of the size of the body that is driving the need to modulate, or the ability to modulate the nociceptive process. And yeah, so it was really cool. It was a hilarious study to do, because particularly the older, wonderful older volunteers that I worked with, they weren't very comfortable with technology. And so you just sort of felt like in one of those cartoons where they're like, this newfangled blah, blah, blah. And you're just like, oh, so good. But yeah, it was a really interesting study, because one of those people that came in, and he was a younger fellow, and we actually wrote up a case study on him, but we were doing the illusion, we're doing a stretch illusion, and it was analgesic for him. And his knee, completely swole up, like in front of my eyes, it just blew up. And it was quite nervous. I was like, oh, I was not anticipating this to happen. That's unfortunate. But he was an excellent guy, and, had was not distressed about this. And he was lovely enough to come back for 2 more sessions so that we could explore this a little bit more, because I said, look, I watched this happen. I have no evidence. I have no numbers to convince people that this has happened. Do you mind coming back? And I'm going to try to do this again, but I'm going to try to also then make it go down. And we were able to replicate that swelling over the next 2 sessions, doing the exact same illusion. And we were able to get the swelling to go down by making his entire leg look little. But that blew my mind, because that's showing, I think, not only do we have this vision about our body part and the way that we perceive our body itself influence how much pain we feel, it's influencing the physiological regulation of something. It's causing that. Well, we watched it be paired in time, and didn't happen with control conditions in terms of increasing that swelling. So that I found was really, really interesting, and to me speaks to some of the power that sensory modulation may have.
On that note, I mean, that type of device might be a ways away, but do you see it being realistic in the next 5-10 years that maybe we can start to incorporate some of these VR devices in the clinical setting to help with some of these people?
Yeah, I think the ones that probably are a little bit linked more to exercise programs and to engagement, to me, have probably the most likelihood of getting into the clinic sooner than later, maybe within the next 5 years, because we see even, Zwift, that blew up because of COVID. And those things, there's the ability to play with some of those programs that might be useful and helpful. In terms of some of the things, I think the systems that we work with are hard. And I think there's an onus on us to, I think, for me, certainly, if I wanted those systems to be in the clinic, I wouldn't feel comfortable doing so until I've done a big trial. And we keep asking for money for this. If you know anyone who would like to give us some money, I'll take it. But
we'll put the word out.
Me, yeah.
Once we become famous, our huge Spotify funds will send that your way. Like, I think we could probably get like $7 right now. Might be able to buy you one of those like snap cameras.
I like it. It's a start. But yeah, so I think that those, like, I tried to take this system. I was giving a course in Vancouver and took the system, and you just need the right lighting. You need different things to make it compelling, because if it doesn't feel real, you don't get an effect with these things. If it doesn't feel like your leg that you're looking at, we don't see an effect. So I think there's probably steps that need to be in place before this goes into the clinic. But what they allow us to do, though, is I think they allow us to explore the mechanisms behind our sensations and our experiences. And even having that extra information allows us, I think, then to challenge those really deeply held beliefs that, how much I hurt is only a reflection of how injured I am, or, those sort of things that I think we require additional information to offset.
Yeah, so I'm just gonna hop in because I think we have this great segue in terms of beliefs, which is, I know is something that we all here love to talk about, and obviously with all your work you do as well. And so one article that I found compelling that you were a part of was with Mary O'Keefe and Chris Marr, when you talked about the necessity for a mass media campaign to kind of change the beliefs that we've seen around back pain. And I really resonated when I read this paper because my family is personally like a history of everyone who has a bad back. And I think a lot of us can say that we all have family members that talk about their bad backs and their limitations. And we know at this point that back pain has a large societal influence and a large belief-based influence. So I just kind of wanted to ask you if you could maybe explore a little bit more and kind of just talk to people and even just talk us through how important you think that societal belief is around back pain.
Yeah, I think it's enormous. And I think what I found really interesting with working with Mary and some of the other co-authors on that was the ability to get something that is catchy, accurate, and has a trusted face on it, because I think inherently we're social beings. And so it's just like, yes, ads on a TV go so far, but if your neighbor says, oh yeah, no, I did this and I had this experience, interestingly, as human beings, we rank that as high or sometimes higher than what for others might be perceived as the more evidence-based information. So I think we have to be quite like purposeful with the way that we do these campaigns. I think it has to be catchy. It has to be something that gets people talking. So whether or not in different areas it might be, slightly more pushing the box for other areas versus a little bit more safe for more conservative areas. But I think one of the things that we had talked about was the possibility of working to ensure that if you searched things like low back pain and wheelchair, what came up is the very first thing was, there's a very tiny likelihood, there's almost a 0% chance you will end up in a wheelchair unless you have been in a car accident and you have, paraplegia or something like that. Something where instead of the inflammatory things coming up first when people go to Dr. Google, it's the evidence-based ones, but also evidence-based in a way that it's communicated that people can understand, because the sites like, some of the NICE guidelines or different Cochrane reviews, they'll come up high, but nobody's going to click on those and understand them. And I mean, they're not also written in a way that's engaging. So I think we just have a lot of opportunities to, work with artists, work with all, the really creative types to find ways that we can push some of this information, because I think it is absolutely critical, because how a society views something, first of all, it dictates your role when you have that experience. You are either delegated to this or that, and that can be really limiting, and it can stop people from being able to speak out. But I think what it also does is it makes it so that your expectations and your prior beliefs are shaped before you even go into any encounter. And if we look at, Bayesian modeling, we have our priors, our past experiences, what we're expecting, and that's combined with sensory information to create this resultant percept of pain. And if we've set the priors so that you're not expecting good things, you think your back is damaged, you think everything's garbage, we've almost dictated the outcome. So I think lots of times as clinicians, we focus on the sensory input and what's going on in the back. But as a society, I think that's why it's critical, because we're influencing the priors.
Ben got really excited as soon as you mentioned Bayesian modeling.
I took Daniel Locken's statistics course this summer. I tried to do it in a week, which is like, it's supposed to be a multi-week course.
That's a hard go.
It's here's my free ad for the X amount of people who listen to it. Go take that course if you're scared of statistics. It's really well done. But yes, Elliot's right. Anytime someone says Bayesian now, I can now say that I understand what it means, and that feels good. So
I have a bit of a follow-up question for you, Tasha. talking about education on a society level, a mass media campaign, fixing Dr. Google, etc. As a clinician or a trainer or some sort of professional that is working with people who are experiencing pain of any kind, chronic persistent back pain or any kind, what is the best place for us to start with educating the patients and having them set down the right path?
Yeah, I think a nice place to start is probably to have a comfortable understanding of pain science and probably some of the complexities that occur within the experience. And it doesn't mean that you have to be expert in it at all, but I think it means understanding that complexity of any experience where it's inherently emergent. It's pain is like, the car or the traffic jam where there's no car accident that you can see, but one person happened to slow down. That caused this other person. That one was looking out of the window, nearly hit that other person, so went on the brakes. And suddenly all these things have occurred together to create a traffic jam without an accident. And that's sometimes, I think, how pain can be, is all these other different influences can co-occur and just seem to happen. And that can be, being told that you have a bad prognosis, having a family member that did end up in a wheelchair, having back pain that you can't explain. All these come together to create this emergent phenomena of chronic pain. And so having, I think, just the general understanding of that complexity can be helpful to then not push that on people, but to help them explore the complexity of their own experience within a therapeutic encounter. And I think the importance, of all of this is as health professionals that are seen as professional within this area and as treaters of things like pain, I think our words have so much more power than sometimes we anticipate. And one of the things that we did, and I'm not sure if, I actually think it's a really good experience and people should try it themselves, but we recorded ourselves talking in a therapeutic encounter, and then we listened to it back. It's excruciating, it's awful, but what's really good is the things that you pick out is like, I didn't actually think that, I thought that I tried to be very positive about this, but when I said this, reflecting back on how the patient took that came out negatively. Or actually, that person only talked for 1/4 of the session. I talked all the rest, which is, very consistent with this podcast. Sorry.
It's fine.
But I think though they're really useful endeavors, because so when we did the pain revolution, where we went around to rural and regional Australia and went to centers to try to push some of the pain understanding and message out, is we'd have people come up and talk to us, and we set up a brain bus that was just in these community, just open community parts. And we had people come up, and it was just so heartbreaking, the things that they took from some of their clinical encounters. Like they said, their lowest point was when they went and they got referred to the specialist that they were finally, able to see after a year. And the specialist said, I can't help you, which that's not a bad thing. If we might have to do that sometimes, but they said, this is never going to change. Your job is just to get used to it. And that's a defining prognostic prior that you have now been given by a really high up expert. And that it's not true. Of course, things can change. It doesn't mean that let's say that exact problem might be cured, but who knows what's contributing to that? If we're only seeing what we saw on the scan as the sole contributor to that pain that person's feeling, well, yes, but that isn't the sole contributor. So I think we just have such power to be able to shape. And so Emma Karen out of our group, she finished her PhD a few years ago. She's done some excellent work on language around scans for back pain, and also how we might frame the importance of exercise and make it safe, make the idea of movement safe for people that may be fearful or in pain.
So I just had a quick question for you. I was mainly just wanting to ask about in regards to history taking. So did you find that maybe your approach to taking a history and asking these questions has changed since maybe graduating I would assume yes, but for us at least, it's usually talking about the primary diagnosis. We talk about that localized pain. Have you found yourself maybe appreciating that kind of secondary history more now, about their occupation, maybe their social history, maybe their past experiences with other healthcare professionals? Because I can tell you, from at least my perspective, we kind of just treat those as, okay, we got to check these off the box now after we've completed the important history. So I'm just wondering your approach now.
Absolutely. I think I think what you're describing is a critical shift, truthfully, because you kind of go through when you're taught, and it's all about asking all those questions, getting through those questions, making sure you have the answer to them so that you can make the picture. And I found that I've moved away from probably more, closed, didactic almost kind of questions to a lot more open ended questions. So things like, you're asking them why they're here today, and they'll usually tell you pain or having trouble doing this. And it'll often, I find, really useful to say, tell me a bit more about your understanding about this. Why do you think it's hurting so much? Why do you think that's really hard? And in that way, trying to get at their beliefs of what's happening in this situation, because I could ask all the red flag questions in the world, but unless I'm getting from them telling me, my wife had this and she had to be off work for a year, and I have the exact same symptoms as her. I'm terrified that this is going to happen to me, and it seems to be getting worse. That's never going to come up on a question, but that's going to be a key aspect that I'm going to need to work with them to challenge, because you're not your wife. Let's look at the things that we're able to change. What happened? She has gotten better, like exploring all those different issues. And I think one thing that I guess really helped cement the importance of psychosocial things as not just something to tick off on a box and say, oh, this is their occupation, this is what they do, is really to remember that when we look at the literature, it's supported by this, that all of these different things, they have literal biological consequences. So when we have negative affect, when we're not feeling good, we have immune changes. Those immune changes in our body can result in changing of transmission of nociceptive information. And that would just be one example. And any thoughts and beliefs that we have, of course, to have a thought or belief, that's a nerve impulse in our brain. And if that nerve impulse in our brain is always being paired, let's say worry, fear, anxiety, with the movement impulses, with the nociception from the back impulses, those can become a unit. Whenever things are firing together all the time, synaptic efficiency increases. They get better at co-activating, and it requires less effort for all of those things to co-activate. So what it means then is one of those things can begin to activate that whole network. So movement can almost activate anxiety, fear, and a nociceptive signature. So I think understanding how the psychological, social, and biological literally interrelate, that to me really helped exploring why I should care about those sorts of things beyond just ensuring that they had social support, for example.
It seems like it's become a bit of a false trichotomy in a way, right? Where you've got the three circles, and folks like Peter Stillwell are really trying to bring everything together, which is awesome. I might be putting you on the spot here, but I want you to try to put your innovator's hat on, because we've talked a little bit about knowledge translation. Where do you think some of the typical education institutions might be able to improve in terms of getting some of these aspects taught to future clinicians? Because certainly we're not getting anything into this much depth through school. So some of the stuff that you discussed there is, being able to really watch the words that you use, try not to accidentally nocebo somebody, because we all know it happens all the time, right? But from your perspective, even in a research position and teaching, where do you think we could change that in the educational institutions?
Yeah, I do think that as the the evidence grows for various different aspects of pain science, I think it does need to be a course within any curriculum, especially the fact that we see so many people that come to us with chronic pain conditions. We can't treat it like acute pain that's just lasted longer. And I think we have to be mindful in the way that we teach that comes across as clear. And of course, even in an acute situation, a lot of other things matter to that experience, but it's not, we are looking at changes in how the system appears to function itself. And I think what's important is it's not to grab onto something as the be all end all, this is exactly what we know everything, but to say, this is the dynamic and this is where we're up to at this point. And so to remember as clinicians that we going out, we always have to keep learning, because we as a science keep, and as a profession keep learning more. So this is the base. We do have to keep going. But I think where we can give that content, but I think there also then has to be the link with seeing that content being used in practice. So I guess one of the challenges we have, and I'm not sure if you find this as well, is if we teach something that's quite new, and then people go out on clinical placement and they might not be seeing some of those things happen, which is understandable, because sometimes the people that they might be mirroring or going out to shadow or work with haven't received that training. So we do sometimes see a disconnect with that. So I think there is a real impetus on us to reach out to the people that are, doing so much extra work to take on students, and we appreciate them so much. We need to give back and make sure that they feel comfortable with the content that students are coming out with. But I also think we need to bring in people with lived experience to our teaching programs. So like some of the people I've worked a fair bit with, met and chatted a fair bit with Gilletta, she's out of the US, she's at My Cup of Joe on Twitter. Mm-hmm. And she had experiences with chronic hip pain, and she talks beautifully about her experiences with working with different health clinicians, what helped, what nearly devastated her, and what could have been done better, and even just how to have these dialogues, because we don't come out knowing how to talk about this. Like, it is something we have to learn, and to be able to pick up signs and to be able to know what has been done in the past, so I guess we don't always make those same mistakes. So I think having a consumer with lived experience as part of one of those educational programs, I think is critical, because I mean, talking to her, I'm like, I really could have used you when I was graduating. That would have helped a lot.
So I was just curious if you could talk a little bit about your research on complex regional pain syndrome. I know this is probably like opening a can of worms, but it's such an interesting topic, and we don't really learn about it in the depth I feel that it deserves merit. So maybe just your for dummies version for Mike. But anything that you could just speak to for clarity's perspective would be great.
Yeah, I think even those of us that work a lot in CRPS are still often not knowing what to do. It's really challenging. And I think what I've been struck by, I was in the UK last year and actually doing data collection on a new sample of people with CRPS. And it's the sheer variability that you see in the patients that come in that have this, that it makes me want to understand why that variability is there so much, why some people have, X as the primary symptom versus Y. But what seems to be quite consistent with them is that everything seems to be overprotective, and that pushing through things doesn't seem to be helpful. It seems to be to make things worse. So when we have people sometimes, let's say, that have back pain, and even though it's hurting when they're doing that, we often get them moving and assuring them it's sore but safe, which is absolutely true. If we push too much in CRPS, I have not seen good outcomes. And so I feel like in that way, it is somewhat of a unique condition. But what I love about it is, I think probably the most important thing for CRPS is that if we catch them early and we can intervene and get them moving before things are too bad, that seems to help a lot. So there's really innovative work that's going on right now out of, I can't remember what hospital, the exact name. I want to say the Royal Melbourne Hospital, maybe in Victoria. And they were finding that people with upper limb fractures, they were not getting detected early enough if they had signs that were reminiscent or predictive maybe of CRPS, and they were ultimately having bad outcomes. And they changed their whole system so that they were detected early. And then they did actually graded motor imagery type things, but they also created a graded sensory program. So a little bit, not in the form of desensitization, but it's actually sensory discrimination of touch, of fabrics, of requiring them to focus and concentrate and discriminate tactile sensation and not just location, the actual qualities. And they had beautiful outcomes, and they're hoping to test that in a bigger trial. So I think from the terms of CRPS, our biggest push is to try to help create the systems to catch it early. And that might be going out of our traditional roles, but trying to talk to people that are involved in service management if you're working at a hospital and saying, this isn't working, we're not picking them up, the process needs to change. But I think it also is having a really trusted relationship with them to then go through, I think, some of those slow steps. So the best effects I've seen have been with graded motor imagery, where we are trying to sneak under the radar of a sensitive system by starting with those left-right judgments where we're activating areas of the brain that are involved with movement planning, but not involved with actual movement itself. So almost instead of movement always being paired with pain, the experience of pain, trying to relearn movement without the experience of pain. And so moving from those left-right judgments to then imagining doing different movements, which again doesn't involve that motor cortex yet, and then to mirror therapy. And to me, that's where I have seen the best results.
Yeah, that stuff is CRPS in 5 minutes is no small feat. So thank you for doing your very best to try to. Mike did a great job of not putting you on the spot there entirely. So we're thankful for him for those.
That's all I'm here for. I just put people on spots.
How can we create the sharpest transition for the most complicated topics? Okay, moving on. Speaking of sharp transitions, I'm going to do one too, because I wanted to talk about this. I spoke with Dave earlier today because I think this is really important. And it's actually something that's been going on the past few days on Twitter, which I know that you're fairly active on sometimes from time to time. And I know what we've seen online. And we can talk about this with you or not. It's completely fine for your comfort levels. But there's been there's interesting exchange going on between BJSM's Twitter account and Laura Rathbone, and talking about kind of this disproportionate relationship we're still seeing in science. And believe me, I'm acutely aware of the optics, given that we are 4 straight white men on a podcast. And I try to be completely conscious of where we sit on our realm of privilege and where we sit in our domain of the power hierarchy. But I thought the conversation on Twitter took a really interesting turn in that we're still seeing such this kind of ridiculous discrepancy in terms of publication bias, in terms of power dynamics that we're still seeing in science and in healthcare. So I just wanted to give you an opportunity, if you wanted to, just to kind of speak on that from your perspective.
Sure. Yeah, it's been an intriguing read, hasn't it? I feel like I don't have to watch any soap operas or anything because I just go on Twitter and get your salacious details. But I think BJSM asked a really lovely and important question, and that really is this idea of, is it a problem if we get a paper that comes in with all one sex or gender on that paper? And they were specifically referring to an all-male submission. And I think it raised such interesting questions because I think there's been literal takes of this where people have said, well, no, of course it's not a problem because everyone has the opportunity to submit wherever they would like. And I think that is not really looking at the depth of the issue. And I guess, and for all of us, and I include myself very much within this, is that we all have varying levels of privilege based on who we are and what our background is. And so I have more likely more opportunities than some people of color. But I think, or you know, people that that don't meet maybe other society, what we consider as the average person. But where I think is actually really important is if we understand that those things exist. First of all, I think that's the first step. So we do know, I mean, you look back in the history and many, if I go into the, I guess, gender aspect of it, many women that made important contributions to various different research findings or discoveries, they're not on those papers. Sometimes they weren't allowed to be on those papers. Nobel Prizes have been given to the men that did the report after the woman found it. And when we know documented cases of this. So there is historical background to this. But it's also the idea of what I was trying to engage with some of this is to kind of explain that if we care about making things we should care about making things as inclusive as possible and making and promoting, I think, diversity, because with diversity, we have the most opportunity to create something that can have widespread generalized impact. Because what if much of what we're doing hasn't had impact because we've only come at it as input, as, let's say, as a researcher? If we only have researchers in a group that is looking to treat chronic pain, and we don't consider or consult with, let's say, people who have pain, likely what we produce is not going to be as good as if we are engaging with a more diverse audience. And I think that's true of everything. So if it's all male, your ideas that you come up with will probably be most palatable and interesting to people that are also male. If it's all female, we would argue the exact same thing. I think compounded on top of this issue is that when it's something that's coming in that is from the highest privileged group, I think what we're asking and what I think is important is that we purposefully try to be inclusive, because I think we have the greatest chance of having impactful, meaningful outputs if we are, you know, diverse and inclusive, because I see that we have a role, and we all do. So one of the things actually that we're discussing at our lab group on Monday is what procedures do we need to put into place to ensure that we give opportunities to other people that might be less likely to get those opportunities for things that are outside of their control, whether they're person of color, whether they are not heteronormative, so really trying to be purposeful with actions. And so that's where I think with this BJSM discussion, what was really lovely and what I hope comes out of it is a policy that says they promote diversity. And I don't know that we're at the stage where we need to reject papers, for example, if they had all male authors, or reject papers if they had all female authors. But if you know a journal's aim and mission is to do this is what we want, is diversity. To me, then that's a really strong message. And it might be that you get a little note and say, just noting, I noted that all the people on your paper were this, just something to consider in the future. I think that could be a lovely thing to start that change. And I think it requires purposeful change.
Yeah, I think that's exactly how I ended up looking at it too personally. It's just in this day and age, and with how many amazing and influential researchers we see across the globe who represent all fields of Earth, it's kind of absurd at this point to not appreciate that there's an impossibility to bring an inclusive and appropriate view on so many different domains, especially in the domains that I think that we try to occupy, looking at pain research and other types of sensory research. Like, every one of those people are a unique individual that represents a unique aspect of the walk of Earth. And to assume that we can't have researchers and can't have patient representation across that, we're hindering ourselves at that point. So thank you. I really appreciate you speaking on that.
Oh, no worries. I agree. Absolutely.
And that was said during our first podcast with a female.
There it is.
Good.
No, that was great input there. We don't want to take too much more of your time, but I am going to ask you, what's in Professor Stanton's future? So where are we looking at, whether that's with your endeavors in research, whether it's any other direction that you want to go?
Sure.
Yeah.
We're very excited. We're about to start a really big randomized control trial looking at an educational explain pain type intervention for people with knee OA. And looking at its effects. And that I've worked really closely with David Butler and Lorimer Mosley to create and work on that content. So I'm so excited. I'm nervous. We start our pilot patients next week. We've got 2 PhD students on it and they're excited and raring to go. So I can't wait to get to share those results. And it's just been a really, really interesting experience to take some of the basic scientific research that we've done, combine it with the clinical things that are out there and create a resource. And so I think I'm super excited for that stuff coming up. That's probably the main thing that's on my horizon, is getting that up and running. And then we have some other things that are trying to look at conveying knowledge in unique ways. So using experiential learning, and so you're going through things yourself, and also, collaborating with artists to create a multi-sensory experience to enhance learning. That's where some of the things that I'm looking to in the future and starting to get excited about.
Fantastic. Yeah. Butler and Mosley, they definitely seem like they'd be a hoot to be around. I think I saw like a comedians in cars drinking coffee sort of like parody with them, and that gave me a good chuckle. But it always helps when you're having fun along the way, right?
Absolutely.
Yeah, for sure. So that's awesome. As someone who's moved over to Australia, any tips for anybody who might end up going over there to avoid getting in trouble with the animals? I know there's a lot of things out there trying to kill you and stuff, but that we're not familiar with here. We just have bears, right? So
I'd say, just don't go to Queensland. Queensland has all the things that want to kill you everywhere. Everywhere else is seemingly much more normal.
Gotcha.
Queensland, no, but I think like if anyone thinks about truly coming to Australia or doing training here, it's a wonderful experience. And I think if you have a sense of humor, you will fit in well in Australia.
Well, Tasha, thank you so much for your time. That was awesome learning from you. Any last like, this is kind of like your spotlight, if you want to let anybody know about any resources where they can follow you on socials, or any other projects that they could look up for more information on yourself.
Sure. So we have, you can follow me on Twitter if you'd like, at it's Tash_Stanton. And some of our projects will be, the newer ones that are coming up in recruiting will be up on something called Open Science Framework, OSF. So they're not up there yet. We're just in the process of transferring everything over. But that's a place you can go to look at some of the upcoming projects that our lab is doing. And I think good resources are always go to Noi Group. They've developed excellent patient and professional materials, and I think they're fabulous. So that's probably my pitch.
Okay. Thank you so much for your time again.
No worries. And guys, good luck. I'm so excited for all the things that you're doing. It's lovely to hear, people that are excited about thinking outside of the box and questioning why we do what we do. And I just think that's fabulous. So best of luck and keep in touch. Let me know if you're in Australia.